first thing I want to, talk to you guys is, there's this new study came out with Safe PCI, basically talking about traditionally most of the heart cath or the stents in the heart were put through the leg. Now there's an increasing trend that you can do all the same procedures through the hand, through the wrist. The advantage of that is bleeding risk is almost zero. I've had patients who I put a stent and they've gone home in 6 hours. Home. After getting multiple stents, they could even go home same day or even the next day. The good thing is you do the procedure, you can watch your own films, you can eat food sitting up. So they have done a study looking at women population and men population, but this study came out in 2013 looking specifically at women because women are higher risk for bleeding. That if you do procedure through the hand, there's less chances of bleeding or vascular complication. There was another study that came out a little earlier. If you did that in somebody who's having a heart attack, you would save their life. The less chances of having major complications. So that was one study that came out. So I'm going to summarize a few of the studies that were reported in the 2013 just to give you guys an update where cardiology is moving. So next thing was, PREMI trial, basically talking about, usually our understanding is if somebody came with a heart attack, you fix that artery and walk out. Even if they have other arteries with 90% blockage, you fix them later. Some other date, that has been usually the way we were trained, the way we were taught. They did a randomized trial looking at people who had the same approach versus the new approach, which is fix what you need to fix at the same time. So they saw that the patients who got their arteries fixed at the same hospital stay, they had less chances of having another heart attack or dying from it. So that was something that new came out. So people are going to be changing their practice pattern, and if you may end up getting 2 arteries fixed in the same hospital stay. So what's new happening in high blood pressure? Believe it or not, all interventional cardiologists are very excited about high blood pressure right now. Because it's not one of those things, you have high blood pressure, take this medicine, go home, it didn't work, add some more medicine. That's not happening. So what's new happening in high blood pressure? We always looked at renal arteries to see if they have any blockages, but we're moving away from just blockages concept. We're looking at the sympathetic nerves that basically are innervating the renal arteries, renal, kidneys, and see if there can be any intervention that can be done. In the past, if somebody had really, really poorly controlled hypertension, they would go into the sympathetic cord and cut that sympathetic nervous. But now they don't have to. It's a very simple procedure, less than 20 minutes. So what they have come up with is, they looked at this procedure, we call it renal denervation. This procedure would drop the blood pressure by 30 points. So if somebody has a blood pressure usually runs with 150s to 160s, if their blood pressure was treated, they would not need to be on medicine. Or if they're on 5 medicine, they'll probably end up being on only 3 medicines. So it's kind of a right now offer to people who are resistant, who are on 5 medications for blood pressure. But eventually the way it's going to work out, it will be offered for people who have moderate hypertension or who are on 3 medications or 2 medications. So 61% people responded to the treatment, so which is a good thing. When there's a high percentage of people who are responding, this is always a good sign. So this is how the catheter looks like. It's a pretty simple catheter which you can basically go through the femoral artery, or again you could even go through the radial artery and go up there, and I'll show you a little animation how this whole procedure is done. And as I said, you could get discharged same day after that. Like a few hours later, you go home and you're taking 1 or 2 less medicines. Otherwise, I'll just tell you how they're going to basically. I'll play the animation and just give you guys a little understanding of what exactly they are doing. Just being normally very commonly being done in Europe already right now. So now the good thing is, they're doing trials in America and they're finding that people are benefiting from it. So these are the sympathetic nerves that are innervating the kidneys. And then they will show this is the catheter that they will put in the kidney arteries itself. And this generates a radio frequency, generates a little heat from that. And this will lead to basically killing of those nerves, you could say, called denervation. Sometimes people can regenerate those nerves, then they will probably need more treatment or need to go back on the medicines. But you can go there and you can denervate these, basically the sympathetic nerve system. So you can easily do that, and they'll show you how simple this whole procedure is. In my assumption, probably sometime later in the 2015 or 16, it will be available for most of the cath labs. Right now it's being offered only in major centers, but this is going to be what every interventional cardiologist will be doing it, because that's why we all are so excited. Okay, there will be so many more people who could just get a procedure, 20, 30 minutes procedure, and have one less pill to take. Can you imagine how much cost burden high blood pressure has? There are millions of people who have high blood pressure. So basically, I'm going to move to the next slide. So it says it's a pretty simple, straightforward procedure that they've come up with. Okay, now we'll go to some more complex stuff. So high blood pressure, okay, yes, got that understanding. So now going to electrical rhythm problems. What's new in electrical system? Atrial fibrillation. About 10% of people above the age of 75 may have atrial fibrillation. So what's new? It's such a big burden on the society. What to do? All these patients are taking Coumadin. Every month they're coming for a check, or they're taking these expensive medicines, Xarelto, Pradaxa. So whenever we send our patients for surgery, for any reason, valve surgery or a bypass surgery, we're always asking our surgeon, hey, can you clip that appendage? Appendage is an area in the heart which is like a sac. I'm going to show you another animation for that. In that sac, if the blood sits, it forms a clot. So we would always ask the surgeon to suture it or bypass it so that blood doesn't go there and forms a clot. So the risk of stroke goes down. So people thought, okay, why don't we come up with a way somehow go in that pouch, which we call left atrial appendage, and somehow block it so the blood does not even go there in people who have atrial fibrillation. So what they did is, so basically, as I said, in atrial fibrillation, the main problem is just not the rhythm that your heart rate is fast, which can be controlled, it's the stroke. Once you get a stroke, once the brain, part of your brain is dead, it's just basically you are dysfunctional. So they came up with this, Watchman device, which is again done through a vein. You go home next day. They found 40% chances of your stroke is reduced from embolism. It improves the death as well. So less people were dying who had this. There are not many things that we can come in today's world to say, okay, we will save more lives, or improve the mortality, at least in the cardiology, So we're always excited when we can find a way, okay, not just improving the quality. It's like, okay, we are going to make people live longer and have less chances of dying. So this is how that device looks like, It's kind of more like an umbrella. It just goes in there. So in this, they will show you the appendage. And I said that these are done, non-invasively in the cath lab, you go through a vein, and this is now they're going to show you the appendage area. This is the sac that we are, this is like now they're going to go through this. This is called the septum. They'll cross through this. We do this very commonly when we're doing ablation for atrial fibrillation, or if we have to put like a PFO closure. So now this is the area, this is the sac. You see this? This is the sac which is of concern. This sac, if the blood sits in there, it will form a clot. And if that clot moves, it can go anywhere. It can go into your brain, give you a stroke. If it goes into your leg, you may lose your leg, or you may need some urgent surgery. So now they've crossed into the left side of the heart through the vein. And now they're going to redirect this pigtail into the appendage, this little sac. And after that, they'll deliver the whole device there. You can look at that. So now they're shooting contrast to make sure there's no clot. They will do an ultrasound, and then they'll look at that, and then they try to size it. It comes in different size. So they've sized it that this person needs 24 millimeter device. And now they're going to pull back. Isn't that neat? Otherwise this would need an open surgery. So now they've gone, fixed, shoot some contrast, it's not crossing, so blood is not going to go. You've isolated that part of the heart. Bring back, nothing. You're standing up in a couple hours, and then you go home next day. Isn't that fascinating? I'm saying it's just a pretty interesting time,
What's the timeline on that? Is it anything specific?
It's another, I would say mostly these in a year or two will be available to most of the centers. So what's happening, there's a learning curve to these things. And like this is all FDA approved. So there's no FDA hurdles to cross now. It's FDA approved, there are indications for it. And in the next couple of years, you would expect them, most of like our center or Tampa, we should all have it. So now going to the valves, it's like, I'm an interventional cardiologist, we're kind of like always giving kind of bad news to the surgeons because, first of all, nobody likes surgeons, right? Nobody likes surgeons, I offered him surgeon, he's like, I don't want surgeon, he's my patient here, Like, I'd rather get more stents. Give me as many stents you want. I don't want to see the surgeon. So hey, he needed surgery, but no, we fixed all the arteries with stents. Valves used to be a normal understanding. Oh, you have a valve problem. It's a surgical disease. Surgeons are going to fix it. Sorry, we do not have any treatment in our world other than giving you some medicines. Not true anymore. It's not true. So open heart surgery for aortic stenosis or mitral regurgitation, eventually it's a matter of time, will become history. Only very sick people or people who have some structural problem that cannot get the surgery done, they will, be considered for it. So I'm going to talk about mitral clip. What mitral clip does is, mitral regurgitation is when the heart valve, the mitral valve, does not close well. So blood, instead of going in the aorta, it goes back into the left atrium. So somebody said, okay, you know what? If the valve doesn't close very well, if I put in a clip so that it sticks together and some of the leakiness, if it can be improved, then they don't need surgery. Because what does the surgeon do? He doesn't do anything. He opens up and everything, and then he just brings the heart valve closer to bring these valves together. That's it. So they said, okay, instead of doing all that, if there's a simple way that they can go there and bring these valves together, so it's called mitral clip. So it's FDA approved now. I'm going to show you another animation. This is how the clip looks like. So basically you go there and you unscrew, and then this clip hangs onto the mitral valve and keep it together. So that's the mitral clip, the way it looks like. So again, you're going into a vein the same way as we went for putting that Watchman device. They're going to cross through that septum on the top chamber and come into the area of the mitral valve. So they're crossing now. They come up with a wire. That's the area. Now they're in the left atrium, and this is the mitral valve. That's not closing well. So you see these valves, they're not closing adequately. So they're going to go in with this clip. So all this blue jet is not supposed to be there, because blood from the top chamber is supposed to go down and go into the aorta. So now there's all this blue jet. Now they're going to go there, put this clip, bring these valves closer. You see how they brought the valves closer? It's almost like if the surgeon is taking a look at it and just puts a couple stitches. So now he's just left that device there. And now the leakiness of the valve is improved. So for a surgery that usually have anywhere from 2 to 3 months of recovery period, patients are going home next day. You'll be in the hospital for 5 to 7 days, then go to a rehab, and then anybody who's had a heart surgery, they know what they've gone through versus where the technology is going to take them.
Any restrictions on the activity of the patient afterwards?
Have a normal life.
Okay.
Do whatever you need to do.
Are they doing this now?
They're doing this now, right now. The most busiest center is Cedars-Sinai in Los Angeles. And they're even offering it to younger people. I even saw some 35-year-old patient who refused. She's like, I am not going to get the valve surgery. She's like, it's Los Angeles, it's a Hollywood city, so nobody wants to do it. And she got this thing done. She's like, there's no way I want to have this, midline scar. And she got this done. And the guy actually happened to be in the meeting for this valve. This was like almost 7 years ago. So now I went to the investigator meeting, and now after 7 years, this device is approved. So this is amazing how, things are taking really good progress. All right, now coming to aortic valve. Aortic valve has a little different kind of problem. That most common one is aortic valve not opening well. You can have leakiness of the valve as well, but if the valve does not open well, what do you do for that? In the past, You just did medicine if you were not a surgical candidate. Now they have done, actually I forgot to do that. They have done this procedure on a 101-year-old patient. She's 102 now.
Good sign.
So this is called pushing the envelope now, okay? So basically, initially they said, okay, if we send this patient for 2 surgical opinion, 2 surgeons said, oh, I'm not going to operate on this patient because this patient will not make it through the surgery. Then you said, okay, we're going to give you this valve. Now they've got more experience. One of my colleagues, we work together, he's already done more than 60 of these. So now they have come up with high-risk patients. Yes, surgeon will operate, but he's saying you are high risk for this. So now even those patients are qualifying for this procedure. So what is this procedure? I want to show you guys a little animation about that as well. Are these animations helping you guys understand? I thought, if I could verbally say, so I thought this will help. But again, you have to be high risk for surgery or inoperable. So now in this one, you're going into the artery. So you see they're going with a wire first. Then now they're going with a balloon. They're going to go with a balloon. And then you see this heart not beating? What they do is they put a pacemaker and beat your heart at 200 beats per minute. So heart is really not squeezing so that they can position the balloon and then stretch that tight valve. They used to do that, that was the procedure before in the past, and then let's say patient, okay, go live your life. Sorry, this is the best we can do. But now, see, now they've gone with this stent. It's called the stent valve. That's your open heart surgery for the valve. Done through a femoral artery. There are different approaches. You can see the valve working. It's not a science fiction, this is real now. That's what I'm saying, it's a good time to be living, So now it's like, what's there for future, Okay, we've done all this good, cool stuff, Where really we gonna stop? Are we gonna stop somewhere or just, that's why they say, cardiology is, hard to stop them, because we like to just, push the envelope as much as we can. So the next thing I want to just briefly touch base, and then I'll take all the questions that you guys have. Bioresorbable stent. A stent that you put 6 months later, it is not there. It's not there. Because when we put all these metal stents, ideally we don't want them to stay there forever, right? Because if there's a blockage, we just want it to stretch it open and just come out and be done with it. I have actually met the first patient personally who had this balloon angioplasty done ever. This was a guy from Switzerland and he was visiting New York. So the first angioplasty lasted more than 35 plus years. He was in his 30s and then the doctor decided to just balloon it. So we like to stretch the artery and leave it that way so that we do not leave a foreign body. But we don't have that choice because we do not get satisfactory results. That's why they came up with different kind of stents, the metallic stents, steel stents, whatever stents that they could get. Now they're coming up with stents that will absorb. They are made of like magnesium, zinc, which are basically part of our body. So after 3-6 months, this slowly will go away. There won't be any stent. Because what happens is okay, you put one stent, you come back, your body is forming more plaque in the same area. You say, okay, this stent didn't work. Let me try another different stent. So you put second layer of stent now. 1 year later, patient is back again. Now you're like, okay, now he's again 80% blockage. What do you do now? You put third stent there. But the patient is asking, doc, how many stents can I get? We're like, no, other option is I send you for surgery. So if they can come up with a stent that will reabsorb, you could keep putting those reabsorbable stents every 6 months to a year. Hopefully, hope that this same area does not form a plaque. So that is going to be it's already happening. It's available, but it's not available in America yet. It's still going through the clinical trial process. But that's where we are moving. Thank you, everyone. Now it's time for questions. Please, go ahead.
The metal stent that I have inside, can that be replaced with this? Or is it
No. The stent that you have right now in you is a part of your body now.
It's been not resorbed, but it's grown into it?
Basically, what happens when you put a metal stent, you will form some kind of like a fibrous tissue. Body will try to heal and form an endothelial layer on it. And then that part becomes, as you saw, let me show you. You can see what happens to the stent. See that? That's the stent struts. And you see this? There's a layer around it, inside. So that's become a part of your body now. So
the difference is this one is resorbed and just the blood vessel remains.
Yes, this will get absorbed. This is what will happen after it gets resorbed. This is how your artery is looking. Yes, sir.
Can you put a stent inside of a stent?
Yes,
You can.
you can.
One more question.
Go ahead.
About radiology, radiate stents to clear them?
They used to do that.
They used to do that.
That used to be one of the treatment for it.
They worked on my wife one time.
Very, very unusually done now. We don't do it anymore. Reason being is we've got this drug-coated stents,
Yes.
which have a coating of a specific drug, which slows down the plaque formation in that area. So that radiation treatment we used to do it, means our lab would not even have it now because it's so uncommon. Yes, ma'am.
Well, this is a simple question, but I get confused because when I read something about high blood pressure, they give you different numbers that are safe. And I'm confused, what numbers are safe for you to have?
Okay, in general, in a doctor's office, you want to have your blood pressure below 140.
Below
Okay.
140, okay.
Ideally, we are shooting for blood pressure in the range of 120.
Okay, that's the thing you always hear, but
In the doctor's office, you're a little anxious sometime, you've just parked in, you've been waiting, a little frustrated or something. If your blood pressure is 5 to 10 points higher, I personally do not get excited about that in my practice. I tell patients, go home, check your blood pressure at home, bring me your blood pressure machine, bring me numbers from home.
so that's okay when that happens.
Blood pressure is not supposed to be a static number. If you're anxious, if you're stressed out, if you're in pain, agony, blood pressure will go up. That's normal. Go ahead.
Can all metal stents be removed?
No,
No.
the stents cannot be removed because the effort to do that, if let's say the surgeon wanted to do that, It's not worth it, because it will take way much more time with no advantage, no gain, because it's already a part of your body. So there's no way he can strip it out and expect that, it just cannot be done. Yes?
On a bypass, they usually say around 10 years they will last. Is that true, or how?
It is not true. I tell people, if you have a stent in your heart, if you have had a bypass surgery and you did not change your lifestyle, if you did not do something different, you are a returning customer for sure. So if you did not start watching your cholesterol, what you eat, your stress, your exercise, you are not doing something different, yes, you will be lucky to get 10 years then. Grafts can fail within 1 year, 10% of the grafts will fail. So, but if you've been doing right, I have seen grafts last 27 years. This is the oldest graft that I've seen. Yes, ma'am, you had a question?
Yes. Is there such a thing as your arteries being too small to qualify for a stent?
Okay, too small. Here's the thing, what the surgeons and interventional cardiologists, we treat arteries up to 2 millimeters. If the artery is 2 millimeters, the stent, we have smallest stent. And when we talk about 2 millimeters, it's already too small. You got to think like that, 2 millimeters, So it's already a small branch. Usually the main arteries are going to be bigger than 2 millimeters. Heart has 3 main arteries. They, for most part, are going to be bigger than 2 millimeters. So they are treated with stents. Sometimes you see a side branch that has a blockage, then you're like, if I try to treat that, I cannot put a stent. I can go with a balloon, which is 1.5 millimeters. I can balloon it, but then am I going to risk the big artery? No. So that's the judgment call comes up. But if somebody's continuously having chest pain and they walk for a mile, you got to do what you got to do. Then you have to go and do something for it. Like something would be basically balloon it. Before the stents were not there, the treatment was go in there, balloon it, and come back.
I was told I couldn't have a stent because my arteries were much too small, and due to the location I couldn't. And I had 2 bypasses, and within 8 weeks, the one on the right side became totally occluded, and the one on the left side, the left ascending artery, they said was between 60 and 70% already filled with scar tissue.
Filled with scar tissue?
Yeah.
So,
and they told me there was nothing else they could ever do for me.
okay. Here's the thing, I want you guys to understand what is blockages in the arteries of the heart is the disease, the plaque formation. That's the disease. So we have to attack that disease. Stents are like a temporary fix. You found a little plaque, some area where it's 95% blocked. You go in with a stent, stretched it out, and you came out. You did not do anything much to the plaque formation. I know they are coming up with drug-coated stents, which slows down this plaque formation, but the overall plaque formation is not stopped. So once, let's say, you get your bypass surgery, then you you have to change your lifestyle. That's number 1. Number 2, there's something we call small vessel disease. This means the small branches are having disease. If your bypass graft failed because maybe it was too small of an artery to even bypass, and they said, okay, we are here, we'll give it the best shot, we'll put a bypass, attach it, hopefully the blood will